together. We got the kind that lasts forever. We're in this love together. And like berries on the vine, it gets sweeter all the time.
Good morning, everyone. This is Karen Dotson from the Medical College of Wisconsin, and you are joining us at the table this morning. It is a blessing to be here to talk about some very serious issues that are going on right now. So what we're going to talk about as it relates to our health is that we're going to talk about mental health, because that is what is really being recognized for the month of May, and then also stroke month as well. So to do that, Dr. Kevin Izzard and I are going to be having a special guest this morning. Good morning.
Good morning.
And the person that we're going to have maybe in about a half an hour from now is Dr. Rose Dotson, who is a neurologist.
Rose Dotson.
That
name sounds familiar.
It doesn't. I wonder why does it sound familiar, Dr. Izzard?
Who is Rose Dotson?
Rose Dotson is my sister, okay?
All right.
So
Sister Dotson.
Sister Dotson. Uh-huh. And she's going to be here. She's a neurologist, and she's going to be joining us to help us look at how things function in our body as it relates to our mental health. There's also some things about stroke. And then she's going to also tell us some of the fun things and what she's doing now. And so just tune in because she will be joining us shortly. But Dr. Izzard, you were texting me early this morning. Mm-hmm. So you've been up, huh?
I've been up.
And so basically, you all, I wanted to talk about, some of the issues that we are having as it relates to, let's talk about mental health for a little bit.
Before we go there, can I zag on you here?
Come on.
So we had a conversation with the All of Us team. And we want people to know that as of July, the recruitment portion of All of Us is going to be over. So,
well, it's kind of interesting because we're going to be able to do a little bit now. I just found out this week. We'll still be able to do a little bit, but not as much. But there is going to be some. But it's going to be a lot smaller. The team is going to be a lot smaller, but we're still able to do a little bit. So, it keeps changing, Dr. Izzard, from week to week, but that's what we found out right now. So there are some resources to do that. And we found that out this week.
Yeah. So, if we made our case, last year we've been coming to you into your kitchen, to your bedroom, to your car on the first and third Fridays to try to make a case that we believe that Black people, African Americans, we need to be included in these research studies and projects and protocols that are being made. We need to be included in those, and we're trying to make the case that we want to be included in those, and we want you to make sure that you're being included, that you're at the table, not on the menu.
Oh, I like that. At the table, not on the menu, because when we're on the menu, what does that mean, Doctor?
That's right. When you're on the menu, that's the whole thing. They're gonna eat us up. Whether we are intentional about it or not, things go forth, and either they're going to do it with us or without us. And if we're not at the table, we're not decision makers, then we're going to do it in a passive way, and they will use us as they see fit. So, but we make that case. We want you to while you can to really sign up for all of us, because your data matters. It really does.
So for people that want to join, feel free now to go to joinallofus.org, or you can call us at 414-955-2689, and you can join us 414-955-2689. We know that there's going to be where we can schedule appointments for people to come in and give their biosamples definitely until July. There might be some things changing as far as saliva and things like that. But, I want people to know that it's very important that we are a part of this research. And as we were looking at the conversation and, what's really going on with research as it relates to mental health, there have been some things out there that has talked about some of the devastation that goes on in our community as it relates to mental health. One thing about mental health, Dr. Izzard, is that our communities a lot of times feel as
Hmm.
though that they don't want to seek help. They feel like they can do what it needs to be done to help deal with that situation.
Mm-hmm.
And a lot of times there might be some self medication going on. And, when I'm talking about self medication, Dr. Izzard, what am I talking about?
Mm-hmm. Self-medication. So imagine that you got a problem with anxiety, okay, and you don't go to the doctor, you don't get it treated. Well, then you're going to try something that's going to yourself that might help your anxiety. So you might drink because drinking relaxes you. Well, the problem is that you've caused a whole nother issue now because now you have an alcohol problem in addition to the anxiety. Or let's say that you have a problem with depression. You might take something that kind of picks you up. So you might use cocaine or you might use other drugs
Mm,
that are stimulants to kind of pick you up. But what you're doing is because again, you're not doing this under the direction of a mental health professional. You are now causing yourself to have another addiction or another problem with side effects from your own illicit drug use. So yeah, we do know that a lot of people who have um, drug, alcohol, and other drug addictions that they have comorbid psychological problems, anxiety, depression, etc.
and you sent me an article that I thought was really interesting where it talked about in 2022, suicide was the third leading cause of death for Black and African Americans
Mm-hmm.
ages 10 to 24.
Yep.
The
Yeah.
third cause of death.
Isn't that? Yeah.
That's pretty
That
serious.
is. That is. Um, and in fact, when I talk to my usually when I do my what we call well child checks, when you come in for a checkup and you're under 18, we call it a well child check. And so we go through things like, are you growing right? Are you how your teeth look? Are you um how's your mental health? And then usually at the end, I tell the young people. I said people under 25 generally. I said, well, I said when I'm talking to people your parents' age, we're talking about uh, and we're trying to prevent premature death, we're talking about things like cancers. We're talking about things like heart disease. But I said at your age, not that it's impossible for someone under 25 to have a heart attack, or it's impossible for them to have cancer. But I said it's unlikely. The thing they're most likely to die from at that age would be accidents. So I tell them make sure you wear your seatbelts, make sure you wear a helmet if you ride a bike
Mm.
or a motorcycle. But with my black patients, especially my black men under 25, I tell them that also probably higher than that is actually homicide.
Mm, mm,
And so
definitely.
so if you're going to prevent premature death, you got to really pay attention to your environment. Try not to be in the wrong place at the wrong time. You got to have the right associates because oftentimes, our black men are victims of homicide, but they might not be the intended person. They might not be the intended target. They just happen to be in the wrong place at the wrong time. People can't aim straight, and they hit somebody else. So
Hmm.
yeah, so I warn them about homicide. But yeah, the suicide thing though is really sad that one of the leading causes of premature death in young people is suicide.
I was just wondering at this age because this is an age when the hormones start kicking in,
Mm-hmm.
and there's a lot of confusion sometimes with our teens based on the hormones. So it could be some physical issues too that kind of help bring this on.
Yeah,
I
yeah.
think a lot of times kids or the young people, and I call them kids because I'm a lot older these days,
Mm-hmm.
but the young people, they have insecurities about themselves.
Yeah,
And
yeah.
so, trying to belong and trying to feel comfortable
Mm-hmm.
around others. And so I
Yeah.
think those are some of the causes of that, Dr.
Right,
Izzy.
right, yeah, and a lot of it is like especially young women, they um, it's funny because when young women try to hurt themselves, they'll use pills, so they'll overdose on something. When young men do it, they're more likely to use something more lethal like guns. Um, and so, but the suicide rate with black women is higher than with men, and a lot of times, almost invariably, it's over some dude. They broke up with
Wow,
their
wow.
boyfriend, and they just want to kill themselves, or they don't necessarily want to kill themselves, but they want to get attention we call it attention-seeking behavior, and so they might overdose, and then let people know that, oh, I took a bunch of pills, or do it when someone's going to see them, because really what they're seeking is attention. They're seeking someone to take them seriously and to help them. But one of the drugs that people take a lot of times because it's so available is Tylenol. But do not overdose on Tylenol.
Yeah, because that really affects a lot of your organs,
it messes up your liver,
especially if you
Yeah.
live. Okay, talk about that a little bit.
Yeah, it's really, overdosing on acetaminophen and Tylenol really can damage your liver, and so they might be doing something trying to get attention, but now they've caused themselves to have a real problem.
Mm. So, when I was looking through and just reading and just having conversations as well, as far as how African Americans really look at mental health as somewhat of a weakness.
Mm-hmm.
In our communities, we feel like if we go get help for, go see a psychiatrist or a therapist, then it shows a sign of weakness. And so a lot of times people try to um, ignore it
Mm-hmm.
in a sense.
Yeah. So a lot of it kind of goes back to our history. We not, we've been we, I mean, as a people, we've been through a lot, and so we do have a resilience. I think that's um, unmatched. In fact, when you look at the suicide rate, even though it's high, it's the third leading cause for young people and African Americans. Our suicide rate is actually less than white people. That's actually one of the few areas that we've been talking about, where we actually do better, than white people. And so, if you look at the suicide rate for people over 18, so adults, for non-Hispanic white people, so white people is 14 per 100,000 people. For black people, it's 11.4 per 100,000 people. So we're 20% less than white people as far as suicide rate. Um, and I think a lot of it has to do with again, resilience, and probably a lot has to do with expectations too. I think we can deal with with the slings and arrows of life, I think, better
Mhm.
than some of well, I don't want to say snowflakes, but yeah, there are a lot of snowflakes
Yeah,
out there.
yeah,
They
yeah.
can't handle when something bad happens to them.
And then, I also think it's because of our faith in God and
Yes.
churches, because we have a lot of churches in our communities. And so, that helps, I believe, as well,
Mm-hmm.
with giving you the support that you need, and having your faith and having that support system helps out a lot,
Yeah.
because it allows for you to start analyzing yourself in a sense, and also realizing that there's a higher being that can also help you, and then you're not on this journey by yourself.
Right.
And
I
so,
agree.
yeah, so I think that might have something to do with it too, when I was looking at those at that data and
Yeah.
those percentages there.
Yeah.
Yeah.
Another thing that's interesting is that, and again, this probably is not a surprise, but as you look at poverty, so if you live below the poverty level, your chance of having depression is like 6 times or 4 times lower, or higher, I should say, than if you have a income that's above poverty level. So yeah, and a lot of us do deal with that. So even though we might have higher rates of anxiety and depression and stressors, to put it that way, stress, our suicide rate is less.
Well, and that's another thing when we start looking at, and we're going to have some conversation with our guests a little later today, because sometimes it might be some physical things that are going on with those individuals
Mm,
that can affect their mental health as
yeah,
well.
yeah,
And so I know Dr. Rose Dotson will be having some conversation with us about that, and so we can kind of think about how we want to move forward. And talk about some other issues. Like, we also know that this month is Stroke Month, and so over half Black adults have high blood pressure. So that's over 50% of us. So if we get 10 people in the room, it might be 5 or 6 of us that have high blood pressure.
hmm
Am I correct on that, Doc?
yeah, yeah. And we've mentioned it, on the show before that we're twice as likely to, to have dementia, Alzheimer's, and those things, and stroke. We have a higher chance of stroke because of the high blood pressure. A lot of times untreated, and so we need to make sure that. I was talking with a patient. In fact, I just went through this last week. It was always on a Friday. Someone's always calling on Friday afternoon with something, and you're trying to
Mm,
figure out how to get them taken care of before the weekend. But this lady was
okay.
called in because she said she just woke up. She worked second shift. She just woke up, and it was 3:30, and she said, and I'm slurred. My speech is not right, and I'm drooling. What should I do?
Mm,
And I told her, go to the emergency room, and she didn't want to go. So I called over there, told them she was coming. Um, but there's a thing called the acronym we use called FAST, FAST, and that's something to keep in mind. If you think you're having a stroke, F is for face. So look at your face. Do you have a facial droop? Is one side of the face lower than the other, or you can't? If you try to smile, does it the one side look different than the other side? Uh, A is for arm. So you kind of lift your arms. You have weakness on one arm versus the other arm. S is for speech. Are you slurring your words? Are you drooling? And those are three big signs that you might be having a stroke. And T is the most important one. T stands for time, and we like to within 3 hours, but as soon as possible. We wanted to get if there's a medication you can take that will break that clot, because usually what's going on is there's a clot in your brain that's preventing the blood from getting to your neurons, and so you start having these stroke symptoms. Um, some of that's reversible, so it may be what's called ischemia. So you might not have totally, it might not be totally blocked. It might just have a lot less than it needs, and so you develop those symptoms. But if you can break that clot, you get blood flow going back, and it recover from it. But the problem though is that there's different kinds of strokes. There's a stroke where you have a blood clot, and then there's what they call hemorrhagic stroke, where you actually have bleeding in the brain. Now you imagine if you have bleeding in your brain causing your stroke, and you give something to break the clot, you make that stroke worse. So no, we don't want to give anybody medication to block or to dissolve a clot if you have a hemorrhagic stroke. So you have to, within that time that we talked about, that's so important. You have to also have a CAT scan to make sure that you don't have bleeding in your brain. So all that takes time. So that's why you don't want to sit around for a couple hours to see, oh, this going to get better. If you're having a stroke, get over to the hospital, get to the ER right away.
I agree. And sometimes, and and I know that Dr. Rose Dotson is going to talk about that too, because I know we've had relatives in the past that had strokes and they had their kids take them to the hospital. She's like, they should have called the emergency. They should
Yeah.
have called and had the ambulance take them, because the sooner you get there, it allows for you to get that medication that you need
Hmm.
to get that treatment. And time is so important.
Yeah.
Time is so important. And we have a caller on the line. Good morning, caller.
Good
Thank you
morning,
for
caller.
joining us at
Good,
the table this morning.
good morning. Thank you. Assalamu alaikum to you, everyone in the studio, and thank you for taking my call.
All right.
I'm
Peace to you,
listening.
brother.
Yes, sir. Um, listening to you all speak about pretty much the elongation or the prolonging of our existence on the planet, and I believe it was the the young lady that she was speaking about high blood pressure,
Hmm.
and I wanted to incorporate this into our conversation or the conversation this
Hmm.
morning. That what we should also consider as paramount, or that is of extreme importance, is that what we intake with regard to like food, the things that we ingest, our habits, and primarily I wanted to focus on pork,
Hmm.
swine,
Hmm.
and swine itself. Most of our people who are suffering from a lot of maladies, and especially high blood pressure, it has to do more so with the uh, consumption of swine, and then you add the reality that we exist in America under, the stress, post-traumatic stress disorder. We probably all have suffered from it or are suffering from it to some extent. So we have a lot of things that weigh on us. There's a lot of gravity on Black people. But I wanted to add to this that what the Most Honorable Elijah Muhammad, he wrote two books, How to Eat to Live, books 1 and 2. And he expresses mathematically with regard to our consumption of food and how we do it more so as opposed to staying away from overconsumption, which is leading to a lot of our malady. And again, I'll go with this: the swine, the pig, is probably at the top of the chart with regard to our consumption. That is the effect of the cause of us being at the top of the list with regard to high blood pressure. Now, there's one more thing I like to share. I met a doctor that I didn't select this doctor. So I went for a physical. And she wanted to, because my blood pressure was high, but I was like, well, I'm active, and I understand other things because this lady don't know me. Like, lady, I just met you. So what are you talking about?
Right.
So she immediately went to prescribe me with some little tiny high blood pressure pills. So, but I understand what to do with regard to myself. I'm with me 100% of the time. So I know what I'm doing and you don't. And I just met you. They just gave you to me. I don't even know you. Anyway, so she tried to get me strung out on high blood pressure pills. She didn't understand that I have worked, I should say, in the production of APIs. And I'm like, I was in charge, or I was the third person in charge, I should say, with the production of something that is used in the detection of cancer. So I'm thinking, like, it's like to understand that I know the process about which these things come into existence. And just because she thinks that she's not a pharmacist, the pharmacist is the one that you should talk to about drugs, because he has or she has all of the technicalities with regard to how that word applies to that particular medicine. Anyway, I didn't take the pills. I utilized turmeric, ginger, cinnamon, and the removal of myself from stressful situations, which will cause cortisol. And I don't have any high blood pressure. So thank you for taking my call.
All right, thank you,
Spices
brother.
and herbs, yes, sir.
Yeah, you made a few points I think that are that bear remarking. For one, yes, definitely our lifestyle has a huge impact on our health. What you choose to eat, how you choose to live, how you respond to stresses in your environment. And so so when you live in a stressful environment, whether you eat pork or not, that's going to contribute to a high blood pressure. There's a theory, and I haven't seen anything that really delved deep in this and to really investigate it. But one of the theories I heard about why African Americans, why we're more likely to have high blood pressure or have a higher rate, is that we've kind of selected that trait in us because during the transatlantic slave movement, when they were bringing over people and as slaves. That passage across the Atlantic was terrible, and so the people who survived it, most cases, a lot of people would not survive that trip. The people who survived it were those who were able to retain water, because dehydration was one of the big things that killed people. So if you were able to keep water better, then you were more likely to survive that. And so now. What keeps water in you, one of the things is salt. So those who retain salt kept water better, and they were less likely to have to succumb to dehydration. Well, what happened is they came over to America, and then our ancestors now generations later, we still have that gene that allowed us to retain water, but now it's causing high blood pressure. So that's one of the theories I heard, and it's actually a very interesting theory.
And we're going to take a quick break, Dr. Kevin Izzard. But
Mhm.
what I want to do is that I want for us to also respond back to the gentleman that said that he felt as though it would be he didn't want to be addicted to the medication
Oh,
for high blood
yes,
pressure. And
yes.
so I think that's really important for us to have a conversation about that.
Thank you
I
for
think
bringing
it's
that up.
good for having, natural, kinds of remedies, but also it's very important that we also understand and know when medication is needed. And we'll have more conversation about that. This is Karen Dotson. We're at the table this morning. And I also have Dr. Kevin Izzard, who is a family practice physician at the table. We're going to have our guest join us when we return. That's Dr. Rose Dotson, who is a neurologist. And please feel free to call in. welcome everybody back to At the Table with us today. And I have my one of my favorite doctors here today, because I got two of my favorite
All
doctors
right.
here
We'll see
today.
who's number one and number two.
Yeah. But I have Dr. Kevin Izzard. He's a family practice physician. He's also co-investigator for our program at the Medical College of Wisconsin. I can go on and on as far as Cream City president. He's also I always like to throw this in because he's a praise and worship leader, right?
Yes.
For his church. And Dr. Kevin Izzard, I have another one of my very special doctors with me today. I would like for you to introduce Dr. Rose Dotson.
Okay. I want to introduce one of my someone who went to my alma mater, Marquette. Dr. Dotson is a neurologist. Well, she's a semi-retired neurologist. She's not practicing neurology anymore, but I said once a neurologist, always a neurologist, right?
That's right.
Yeah. So she was born and raised here in Milwaukee, went to Marquette, like I said, and she got her MD from the University of Wisconsin Medical School. And she completed her neurology residency and her neuromuscular fellowship at UW. And she's also been on the faculty and of several medical schools, including UW, the Oregon Health Sciences University, and the Medical College of Wisconsin, Mayo Clinic, Case Western University. So she's been around. Where she was an associate professor of neurology, I think is where I first encountered her. She's been a neuromuscular and autonomic and pain subspecialist. Wow. And a clinical researcher. So I tell you, this sister does not play. There was no time for playing and all that.
And I can say, literally, that is my sister. And so
Yes.
I know a lot of times our callers are calling in and they're thinking like, Dr. Dotson. I'm like, nope, I'm not a doctor, but I do have a sister that's one.
Yeah.
And so Dr. Kevin Izzard, we wanted to bring Dr. Rose Dotson on today for a couple of things. And go ahead.
But actually, before we get to Dr. Dotson, maybe she might want to chime in on this too. There were a couple other things that last caller said.
Oh, yes.
And we talked about high blood pressure. Now, the reason why he made a statement about the doctor who pushed these small pills, tried to get them addicted to these blood pressure pills. Number one, blood pressure pills don't cause addiction. Now, what will happen is you come in, your blood pressure is high. The doctor says start these pills. You come back, your blood pressure is lower, and they say keep taking it. Well, now, some people interpret that to mean, oh, well, now I'm addicted to these. I have to take these pills for the rest of my life. Well, no, what happens is whatever's causing your high blood pressure, you have treated it. You might not have gotten to the root cause of why your blood pressure is high, but at least you have lowered your blood pressure. You've lowered your risk for heart attack. You've lowered your risk for stroke. If you stop taking the medication, guess what? Your blood pressure is going to go back to what it was. So the medication didn't cause you to be addicted to it. It's just that unless you make some changes to get to that root cause, again, change your diet, change the amount of salt you're eating, lose weight, start exercising. If you start doing those things, you might not need the pills. So the reason we tell people to stay on their pills is because whatever was causing that problem is still there. And unless you've dealt with that, the blood pressure pills are an easier way to take care of that. It's easier for me to, when a patient comes in who has high blood pressure, to say, take these pills. I'll see you back in 2 weeks. I'll see you back in a month, get the blood pressure down, and then start working on other things rather than saying, oh, okay, well, your problem is that you're overweight, lose 20 pounds and then it'll be better. Well, that may or may not happen. It's hard to get people to change their diet, to change their lifestyle, and even then to lose weight. So, yes, it is a simple fix. It's not a substitute for doing the other hard work, but it is something that doctors find that they can do in a measurable way rather than because everybody's not going to be committed to making those changes like our caller said, or they were willing to to start exercise and to make those herbal changes. And the problem with the herbs is that they're herbs, but they're medications. I mean, and they're it's a different kind of medication. They're not in most cases regulated by the FDA, the Federal Drug Administration, but they are medications, and so they can interact with other things. Turmeric can affect other things. Cinnamon So I'm not going to discount those things. And if someone tells me that they want to, unless their blood pressure is really, really high, if they tell me they want to make a lifestyle change first, go for it. And even if your doctor does push for you to still be on medication, make those changes. Because what'll happen is, if those changes are working, then you'll find that your blood pressure is getting too low, and then you can come off of the pills. So go ahead and make those changes. Even if you're skeptical of the pills, because the pills are a temporary solution to what's going on with you.
Dr. Rose Dotson, a lot of times they mention that high blood pressure is a silent killer. And so a lot of times we go and we don't know that we have it. And a gentleman just called in a little bit earlier and said that he wanted to do the natural route. And that's what Dr. Izzard was talking about. And on a neurology standpoint, can you kind of give us some ideas on some other things that people might want to consider? Of course, take your medication, but then there's some other things that they can do too. I know that you have been, doing some special things with your diet and exercise and all those things too.
Especially someone who deals with stroke. I'm sure that was a big thing for you, blood pressure.
Most definitely. And actually, hypertension or high blood pressure is the number one controllable risk factor for stroke. So there are a number of risk factors for stroke, but that is the one that people can control. And I have to agree with what Dr. Izzard said. You really need to control your blood pressure as quickly and as completely as you can. So taking the medication that's prescribed is appropriate. But we, as Dr. Izzard said, know that if you lose weight, which is challenging, been a challenge for me much of my life, and I'm always working on it.
And mine.
Still is right now.
I'm always working on it. And exercising, eating appropriately, watching the salt in your diet. But the other thing we know that's important is sleep. And
Yes.
getting enough sleep is something that has been added to the list of things that we can do. If you don't get enough sleep, for instance, if you have sleep apnea where your airway is blocked and you can't sleep well, or if you have, chronic pain that keeps you awake, or if you have just insomnia or some other sleep disturbance, that can significantly elevate your blood pressure. So improving your sleep is another thing that I would add to the list that can be beneficial. So those are things that we all need to work on.
Right. And I 100% agree with you that, you make those changes, it's definitely going to have, a positive effect on your health, and maybe you won't need medication. I think that's the ideal situation. But again, if you're not making those changes, and sometimes it's just genetics. I have people that are thin, they're vegetarian or vegan, and they still have high blood pressure.
That's true.
So again, you can't fight the genes. You can control the things that you can control. Dr. Dotson, my question for you. I'm just kind of curious. So how did you choose neurology? At what point did you decide you want to be a neurologist?
Oh, I chose neurology actually after I spent a couple of months doing part of my internship here in Milwaukee. I thought I was going to be an internist when I graduated from medical school. Even though I love neurology, I took extra neurology in medical school. I loved neuroanatomy, neurophysiology, when all my classmates were saying, oh, I can't tolerate this. But 2 months into my internship, I said, I'm going to do what I really want to do. And I chose neurology because it intrigued me, because I had fun studying the brain and the nervous system. I love the idea of being able to do the neurologic exam and then tell people where in their nervous system the problem was and what I thought was most likely the cause. And that was something that a lot of non-neurology colleagues did not enjoy as much. And I felt it was something that I can contribute to medicine. And I just had fun doing it.
Neurology is fascinating. It's we all have to take it in medical school, and it's one of the tougher subjects because not a lot is not known about how the brain works. And so and there's a lot of complicated things interacting with other things, and so a lot of students find it challenging. Again, I really give you kudos, to pursue that further. There's this guy, Oliver Sacks, who's a neurologist, wrote a book called, I think it was The Man Who Thought His Wife Was a Hat. And he talks about these interesting neurological cases, people who've had strokes or other things. And it's fascinating how the brain, I remember doing residency, taking care of patients, a medical student, taking care of the patients who had strokes, and they might have an aphasia where they can understand everything you're saying, but they can't repeat it back to you, or they can't, you look at a table and, they can't pick out the hat, or they can't, so these things where people can process things, but somewhere things are missing, and it get these interesting outcomes, with that.
Yeah, and it actually depends on where in the brain,
Right.
where in the nervous system the stroke occurred.
Mhm.
Because, as I'm sure you remember from
Mhm.
your neurology, there's different types of what we call aphasia, where they have difficulty speaking.
Mhm.
There's Broca's aphasia, where it's the motor part, where they can't say the words, but they can understand the words.
Right.
And then there's Wernicke's aphasia, where they can say them, but they can't understand them, and then what comes out sounds like word salad.
Mhm.
And so it's all about where in the nervous system the stroke has occurred, where that blockage of the blood vessel, has
Mhm.
caused damage to the brain. I like to tell people it's, what a heart attack is, where there's a clot in an artery
Mhm.
that then, causes a part of the heart to die, which is a heart attack or a myocardial infarction. That's what happens in the brain when a person has a stroke, for most of the strokes.
Mhm.
Because we also can have a stroke when somebody bleeds in their brain.
Right. And the thing about strokes too is that you can survive a stroke, but the disability that comes about from that can be devastating.
It's the number one cause for disability in the
Yeah.
United States.
Yeah.
And stroke, unfortunately, still is the number 5 cause for death in the United States.
Mhm.
But the good thing is that we've come a long way in stroke from when I was a medical student. We won't say how long ago that was. And when I was even in the beginning of my practice in neurology, I had my brother-in-law, who was an anesthesiologist, contact me and say, my mother had a stroke, and what can I do? And this was a number of years ago. And I was like, well, she's had this stroke. What can you do now? She needs rehab, and she needs to go to physical therapy, occupational therapy, and if necessary, speech therapy. And she needs to have, find what the underlying cause is and try to prevent another stroke. Well, we've come a long way, as you know, since that time. Because now we actually can do something when somebody's having a stroke.
Mhm.
And why is this important? Almost 800,000 people have a stroke in the United States per year. So
Wow.
think about that. More than the population of the city of Milwaukee.
Mm.
Wow.
And so, and most of those, almost 700,000 of those are the stroke because of the blockage of a blood vessel, which we call an ischemic stroke. And then the rest are because there may have been a bleed in the brain because of a ruptured blood vessel for various reasons. And 80% of those are preventable. So those things that Dr. Izzard was talking about before, about controlling your blood pressure,
Mhm.
Losing weight if you need to lose weight, and exercising, getting enough sleep, watching your diet, all of those things are crucial for preventing. But what do you do when somebody's had one of those strokes where there's a clot or a blockage in the blood vessel? Well, in the past, nothing.
Mhm.
But now we have some medications that can break up that clot. Some people call them the clot busting drugs, or thrombolytics. And there's a couple of them that are in use. One in particular has been primarily used in neurology, Alteplase or TPA. And I've had the privilege of being in the emergency room when I got called in to see a patient with a stroke on a number of times. And this person is paralyzed on one side, they can't speak. And you make an assessment, you get them in real quickly and do a CT scan, make sure they didn't bleed in their head, because if they bled, you can't give them this. And then, you have the pharmacist rush in and you give them the medication, and before your eyes sometimes, but definitely over the next several hours, you see the person be able to move their limbs. And I've seen people make a complete recovery, as far as we can tell on their examination, because we prevented that area of the brain from dying.
Wow. Imagine that. I mean, imagine,
Wow.
here you are, have a major stroke, and you can reverse it if you get in them fast enough.
Yes.
And I think that's key, because a lot of times, and Rose, a lot of times you have mentioned that when people have a stroke, they shouldn't drive. They should call the ambulance.
Thank you. And we didn't even plan this, but that is exactly what I wanted to say next, is
Okay.
that if you think you're having a stroke, and we can talk about what some of the signs are, you need to call 911. And this is important. And of course, it's great we're talking about this, because May is Stroke Awareness Month. So we need to talk about it all the time. But
Right.
We should not drive ourselves into the hospital. We should not call our doctor and say, what should I do if we think we're having a stroke? So don't call Dr. Izzard if he's your doctor and say, what should I do? We should not have a family member drive us, because the treatment for a stroke starts in the ambulance. And even with, the people, the EMTs, the emergency medical techs, getting to your home, because they can start to assess you and they have certain criteria that they use in order to, and certain scales that they use on looking at you and examining you briefly to say, is this person having a stroke? They will call the emergency room, contact the emergency room doctor. The emergency room doctor will give them instructions, and some of that instruction may be, where does this patient go? Does this patient come to this hospital or
There
another
you go,
hospital?
right.
Is
Yes.
there a stroke center at this hospital? Is there a stroke center that can do some of the advanced treatments that are available? So that's a decision that's made, and you may go to the wrong hospital, or you may have a worsening of your stroke on the way to the hospital that something could be done about. There's even some cities now where then the ambulance, they can do a CT scan and they can, see if you've bled in your brain or not, and with the direction of a neurologist that may be on board there or that they may be communicating with, they can decide about giving you medication. So it's crucial, and thank you for saying that, Karen. It's crucial.
Yeah, you mentioned TPA, how it can be life-saving medication. So what do you say to people who say, oh well, should I just go ahead and take an aspirin if I think I'm having a stroke?
The challenge with that is you don't know if your stroke is because you bled in your head or because you have this blocked blood vessel. If you have the black blood vessel, that could be beneficial. But if somebody's getting TPA when they get there, one of the things that we don't give them is aspirin. You don't want to give them anything else that will thin the blood. And so they can't take that for some time. The other thing I want to say is some people say, well, they can give me that drug up to 4.5 hours. So maybe I'll wait a couple hours. No. The sooner you get in there, the better, because you want to save brain cells, and you lose a significant number of brain cells every minute, hour that you delay, and that there's this clot that's blocking the blood vessel. And so the goal is to get that medication into people within 4.5 hours of the onset of symptoms. And so we usually say the last time known well. So if you went to bed and you were well, that was your last known time of being well. And so when you wake up 8 hours later, because hopefully you got a good night's sleep, you wake up 8 hours later and you have symptoms of a stroke. And I've had patients do that where they just say, I got up and I couldn't get out of bed, or I stood up and I fell, because they're weak on one side. We don't always know when that stroke occurred. And so then we typically would not give them TPA or Alteplase, that clot busting medication, because it may have been more than 4.5 hours, and that increases their risk of having bleeding, which is the main complication of this medication.
You mentioned a very important point too. So if you're dealing with a family member who had a stroke and you're taking them to the ER and they can't tell us what's going on, they're going to ask you, when's the last time you saw that person well? So make sure you get that information, because they want to know that.
It's crucial.
Yeah,
it's crucial. And if you're past that time window where you could get the clot busting medication, what do you do then?
Right.
So the next thing is, that's why you want to be careful about where you go, because here in Milwaukee, there's only 2 places that will do what we call a thrombectomy, which is where they actually can put a catheter in through a blood vessel and go up into the brain and remove a clot from some of the larger blood vessels. And that's something that you can do as long as most hospitals are saying that you need to do that within 24 hours of the onset or the last known well time. And so that's the other thing that can be done. And I've had some patients where, again, this person had a major stroke. I was at Aurora and Grafton for a while, so I had an opportunity to send people either to the medical college, to Frederick, or send them to, St. Luke's here in Milwaukee, the 2 places that do this. And they would go in, I tell them what's going on, this is what I think, and they, there's special MRI imaging and CT scans that you can do where you can see, how bad is this stroke, or the stroke that's starting or occurring, what area could be saved, how much can be saved. There's all these complicating things, but they can go in, get that clot out. And I've had people that have recovered from that with that particular procedure. So it's amazing what we can do now. And so that's some of what I've been able to witness. And it always makes me think about my colleagues when I said, I'm not going to do internal medicine, I'm going to do neurology. And they said, neurologists don't do anything for people. All they do is tell people what's wrong with them.
Yes.
And I can say that's not true.
A lot of times people are worried about getting the bill for ambulance transportation, but like you said, if this is your life,
Yes.
and the cost of prolonging a stroke and causing permanent disability is going to far offset any cost that you might have for ambulance or an ER visit.
And remember that stroke is the number 5 cause of death in the United States.
Mm.
So
Wow.
you may be dead or disabled, but you're not good options.
Wow, that's interesting. And, also, Rose, when you were talking about, people were saying why you want to be a neurologist. And, I did some research and I looked at that since 2024, they indicate that only 3% of neurologists in United States are Black. And
Hmm.
so that is a very small percentage of neurologists for us in the country, not just in
Hmm.
Wisconsin.
Mm-hmm.
Most definitely. When I went into neurology in a few years ago, let's say
Okay.
that,
Yeah, we'll say a few years ago. Okay.
it was primarily white males.
Mm-hmm.
So you really had
and
a,
that made it challenging
I was going to say
because
you had
they
a
would
hard time.
challenge you as far as why are you doing this and what is your
Mhm.
knowledge. But I like challenges.
Yeah.
And because I enjoyed neurology so much, it was something that I had the opportunity to do well in it.
And we talk about this, at home a lot in different places as far as like, because one thing that, Dr. Izzard, we kind of talk about like the career of how did you get there and,
Mhm.
what challenges did you have and why did you decide to do it? And how can you say that you made this journey work for you? Because there were challenges doing this and going to school.
Yeah. Well, I'm sure Dr. Izzard can share some of that too, because he had to go through. We went through some of the same schools, and
Yeah.
even though I'm a little bit ahead of him, I'm sure it was still challenging. But what I would say is that one, I'm a person who prays.
Amen.
I'm
Amen.
a person who believes in the power of God and the power of the Holy Spirit, and I know that I don't do and I did not do the things that I have done without Him.
Mhm.
Without God, without lots of prayer. And I had praying grandmother, praying mother,
Hmm.
praying father, praying sisters. So I um, have to give God the credit first. And then I had very supportive family. I had parents who believed in me, told me from when I was in elementary school that I was going to be a doctor. And I always say they brainwashed me because they gave me
See, the same thing I say, right?
doctor
Same
kits
words.
and
Oh, she
chemistry
was mixing
sets.
up things.
I had my sisters, Karen, my other sister, were my chemistry assistants. And by the way, chemistry was fun. I did chemistry for fun and at Marquette as a biology major and a chemistry minor. But they were encouraging. People of my church encouraged me when I said I wanted to be a doctor. And then I just decided that this is what I am going to do. And so when things got hard, I had to take some time. I had to pray. I had to, do whatever I could to take care of myself because medical school and residency can be challenging when you don't get enough sleep and when you don't have time to eat and when they're calling you to the Trauma Life Support Center at the University of Wisconsin Hospital and you're a junior neurology resident who's just getting started and just finished an internship and you're on a neurosurgery rotation and this patient is tanking and about to potentially, and unfortunately the patient did die. But as a 19-year-old, and I'm thinking I'm the neurosurgeon on call. I'm like, oh my goodness, I had to drop my lunch and run into the Trauma Life Support Center. And those are times when, as I'm running in there to see what's happening with this young man, I'm calling on God, to strengthen me. And then I had mentors. I had people in medical school that saw my abilities and encouraged me. I had a physician at my church, Dr. Tom Jackson, who was the former director of the primary care clinic here in Milwaukee, and an internist and professor at the University of Wisconsin, who encouraged me and mentored me. So that's how. And then you work hard.
You work hard.
You spend the time.
Yeah, we're going to take a quick break and we're going to come back. This is Karen Dotson from the Medical College of Wisconsin. I have Dr. Kevin Izzard, who is a family practice physician, and Dr. Rose Dotson, who is a neurologist. We have a caller on the line. Caller, hang in there. We're going to get to you when we come back. We got to take a quick break, and we'll see you on the other side.
don't want to lose it. It's like a favorite song that we love to sing. Every time we hear the music.
I want to welcome everybody back. This is Karen Dotson, and we're at the table today. We're talking about mental health. We're also talking about stroke. And we have one of my favorite doctors, my sister, Dr. Rose Dotson, who is a neurologist. Want to say welcome, Rose. Welcome.
Thank you so much, Karen.
I'm so glad that you're at the table with us.
I'm glad to be here. I appreciate the invitation.
You know, we talked about you being a neurologist, but there's some other things that you've been doing too. But we had a caller on the line, and I want to bring them on. So good morning, caller.
Oh, can you hear me?
I can hear you. Good morning, and thank you for calling to sit at the table with us.
Oh, thank you for being here. I just love listening to you every Friday so much. Question. I am a 62-year-old person, and I'm wondering, should I be taking a bear aspirin every day? The baby bear aspirins. Some say yes and some says no.
I'll answer that. Thank you for calling. You should not be taking a bear aspirin or baby aspirin, 81 milligram, low dose aspirin. Those are all the same thing, unless your healthcare provider or doctor tells you that you should.
No, he didn't tell me.
Yeah, because there's some recent studies showing that unless you've had a previous heart attack, had a previous stroke, which may be some of the reasons that you would have someone take that for prevention of another heart attack or stroke, that you can increase the chances of bleeding, and especially as we get past the age of 60, the chances of having some bleeding problems either in your stomach or your gastrointestinal system or other places increases. So the recommendation is that you don't just take it on your own.
Thank you so much. Okay, that's all I needed to know. And again, I really appreciate you guys.
You're welcome.
Thank you for calling and being at the table today. And for those that are interested in calling and talking to a neurologist, because we don't get this opportunity too much on air. And so you can call us at 414-444-5253, 414-444-5250. And Dr. Rose Dotson, when we were introducing you, there were a lot of different areas of expertise that you've been doing. So what is a neuromuscular? What area is that you've been working with?
So I did special training after I completed my neurology residency, which is the training you do after medical school to become a neurologist. And a neuromuscular neurologist is a neurologist who takes care of problems of the muscles, that's the muscular part, and the peripheral nerves, and that's the nerves after they have left the brain primarily, or the spinal cord, and that's what we call peripheral nerves. And so that includes a number of things. It includes diagnosing and treating people that may have muscle diseases that we call myopathies that could be inherited or can be something that is acquired. Sometimes it's because of inflammation in the muscle, because the immune system is attacking the muscle. We take care of people that have, people probably heard of ALS, or amyotrophic lateral sclerosis, which is otherwise known as Lou Gehrig's disease, which is where the motor nerve cells, and actually in the brain, as well as in the spinal cord, and the nerves that result from that are affected. And that can be inherited or acquired. And then people unfortunately succumb to that usually within less than 5 years, and sometimes even within a couple of years, because it affects the nerves that allow you to breathe and the nerves that allow you to walk and to move and to swallow and to speak, and various people may be involved in their nerves may be involved in various ways. It also includes taking care of people that have muscular dystrophy, and people have heard about that. You remember back in the day, they had the muscular dystrophy telethon. Mm-hmm. I was a co-director of the muscular dystrophy clinic for Froedtert and the medical college and for Children's Hospital when I worked there in the past. And so I saw children that unfortunately sometimes I would have to tell their parents after I used to do the electrical test of the nerves and the muscles. That's something a neuromuscular doctor does. An EMG, or electromyography, people may have heard of or may have had it done if you've had carpal tunnel or if you have diabetic neuropathy. And so sometimes I would do that test and have to tell people your child's not going to live past the age of 3.
Ooh, that's
But the good
hard.
news is, and that was because of something called spinal muscular atrophy, which is another motor neuron problem. But now there's some treatments that are available that can improve that have significantly improved the prognosis, so that that's not the case any longer. And also, as a neuromuscular person, I took care of people that had what we call peripheral neuropathy. One of the number one causes actually in this country is diabetes. When people say their feet get numb and they're painful, or their hands are numb, and they're losing strength and having difficulty with movement because of their nerves being affected by diabetes. So we take care of people that have that, but there's a long list of causes of neuropathy. It's multiple different diseases of multiple different causes, of which diabetes is the number one cause in this country. And so we would take care of people with that. And so I do the electrical test of the nerves and the muscles. In the past, I've done biopsies where I, had to go into the operating room and take a piece of muscle from a person or a piece of nerve from a person. And then I was the person who would read it and look at it and help make a diagnosis, to determine, help try and determine what the cause is. And so that's kind of a brief overview of what a neuromuscular neurologist does.
Thank you. And the reason why I wanted to mention that to our listeners is because they need to know what types of specialty areas and who they should be seeing for different things. And so thank you for that. We have a caller on the line, and I want to say good morning to you, caller. Thank you for sitting at the table with us.
Thank you. And how are you guys doing this morning?
Good. How are you?
Good. Thank you. I had two questions, if you don't mind.
Please, go ahead.
I wanted to ask the neurologist, how does MS affect your brain, and is MS hereditary? And I'll listen off air. Thank you.
Thank you.
Thank you for that question. So MS, or multiple sclerosis, actually is a autoimmune neurologic problem. And it's where the person's own immune system is attacking their nervous system. And MS affects the brain in that way because it causes damage and destruction of nerve cells, and it can occur in multiple different areas, primarily in one area in some people, but it can occur in different areas of the brain, and in the spinal cord. And some people may have more involvement in the spinal cord. Some people may have more in the brain. Some people may just have one spot primarily, that later, after some time, develops into other areas that are affected. And so that's how it's your immune system attacking the nervous system and causing destruction. And then that can result in all kinds of symptoms. It can result in difficulty with thinking. A significant number of patients may have some what we call cognitive problems and trouble with memory, and they may have slurred speech and difficulty with speech. It can affect your eyes. It can affect your ability to walk, to move, your bowels, your bladder. Unfortunately, MS can affect people, and some people get affected in multiple ways with significant disability. The good news is that during this time that I've been involved in neurology, there have been major advancements. We had only a couple of things that we could do to treat people back when I was a medical student, and they didn't work very well. And now we have a multitude of medications. There are neurologists that are multiple sclerosis experts and specialists that take care of the more complicated multiple sclerosis patients, and that can use the various medications depending on what the patient's symptoms are, what the patient's other medical problems may be, and make the right choice of a medication or a combination of medications to not just treat the symptoms, but to treat the underlying process that is causing the destruction of the nerves.
That's really good news. Research, and that's why we stress the importance of being a part of research, because that allows for these type of medications and treatment to take place. We have another caller on the line. Good morning, caller. Thank you for joining us at the table. Hello, caller. Are you with us? I can't hear you if you are there. Caller, are you with us?
Oh, yes, I'm here. I'm sorry.
Okay, great. I thought we lost you. Welcome.
No,
Welcome for joining at the table with us
radio.
today. Thank you for calling.
Good morning. So I have a question regarding my mother's neuropathy diagnosis. So my mother has not been diagnosed with diabetes. However, when she first started having symptoms about 2 years ago, 2.5 years ago, roughly, where it really became a problem with her mobility as far as walking and her hands and stuff and the pain. And she said it feels like needles sometimes poking her. So she hasn't been diagnosed with diabetes, but when she first started saying this, because of my employment history, I thought to myself, like, this sounds like diabetes to me. I'm no medical person by any means. However, the claims that I've seen in the past, this is giving diabetes. And she put off being tested for diabetes for the longest time. And when she finally was tested for it, she did not do the type where she did the fast first for them to get the most accurate results. In my opinion, I think she just doesn't want to be diagnosed with diabetes. And of course, I hope it's not that. We all hope it's not that. But at the same time, her not getting accurate readings doesn't help anything either. So she did see a neurologist, and they ended up doing a biopsy on a muscle in her ankle towards the top of her foot, that area. And they still didn't find the core issue of what this could be or how to treat it. So quite honestly, all she's been doing is taking pain medicine up the ante for about a year now, which I know can't be good for her, but is what she's doing. I guess I'm wondering if you have any suggestions of what else we can be looking at, who else we should potentially be seeing. I know her weight probably plays a part in this as well regarding her mobility, because she's like 385 pounds and she's only 5'7". So any suggestions that you have, I am very much open to, so I know where to try to go with this.
Well, thank you for calling in. This is a challenge. Before I answer you, I just need to get back. The previous caller had also asked about whether or not MS is hereditary. And there may be some hereditary predisposition to MS, but we don't typically think of MS as being hereditary. Now, let me get back to your question. I'm really sorry to hear that your mother's suffering the way that she is. And like I said before, diabetes is the number one cause, and the appropriate testing needs to be done for diabetes. As a person who has done, and it sounds like you described that she had a nerve biopsy, not a muscle biopsy. I could be wrong, but based on what you said, right. the location, that's what it sounds like. And one of the things is that, in my practice, in later years of my practice, I have not been doing nerve biopsies as much as I did in the earlier years, because one of the things that I learned from reading the biopsy and being the person who would help make the diagnosis and seeing patients in the clinic is that the best way to determine what the cause of neuropathy is in someone is, one, taking a really good history and knowing the family history, because some of them are hereditary, but the other is doing laboratory studies. There's only certain cases where I would recommend a nerve biopsy, because what I found from being the person who would read them from all over the state when I worked at the medical college in Frederick and Children's was that most of the time I could say, yep, your patient has a neuropathy on the basis of the biopsy, but I can't say why. But then when I would see patients in clinic, I would, do the things that I said, doing lots of labs and making sure that I had a fasting blood sugar. And if that didn't show it, I would have the patient do a 2-hour glucose tolerance test where they fast and then they get the blood drawn. And then, of course, they have to drink the syrupy, sweet liquid like a lot of us women had to do when we were pregnant. To make sure we didn't have diabetes. I would make sure they did that and do a hemoglobin A1C. So they have to make sure that they rule out the number one cause. And then there's a long list of causes of peripheral neuropathy. And I don't have time to go into all of them, but let's just say that there's a long list of different types of hereditary neuropathy. There is neuropathy that can be associated with kidney disease, liver disease. There's the immune system attacking the nerves in various ways and various types of neuropathy. There are toxins that can cause neuropathy, lead, mercury, arsenic. There are certain drugs that can cause neuropathy. So there's a long list. And what would I recommend? Well, if I was practicing, I'd say she's come see me, but I think that what is important
I
is
wish.
that yes, patients like this make me want to get back in there, because this is a lot of what I did. When I worked at Mayo Clinic in Rochester, Minnesota, I saw people from all over the world who were coming because they had nerve pain and nerve problems and neuropathy, and so you want to make sure that she doesn't just see a neurologist, because if a neurologist can't get to the bottom of it, then she needs to see a neuromuscular or peripheral nerve specialist in neurology. And there are some here in the city of Milwaukee that, you can go and see. There are people at the medical college, and you can look up neuromuscular peripheral nerve. There are people, in other systems here in Milwaukee that could see your mother. And sometimes if they don't have the answers, because when I worked in Rochester, I saw a lot of people from Milwaukee, because I would get referrals from my colleagues at the medical college or from Aurora or from other places. And they would be coming to Mayo Clinic, where you have doctors that have the opportunity to subspecialize and stay very focused and become some of the best in the world at what they do. So that's what I recommend. But the other thing is the patient needs to cooperate. The patient has to be willing to do the testing, to do the examinations, to follow through. And we can't make the patient do anything. And I would tell people it's their choice. I can make the recommendations, and you as her daughter, you can recommend once you have the knowledge and recommend that she do something. But ultimately she has to want to do it, and she has to make the choice for herself, as long as she's, competent and able to make those decisions. Does that help you?
That does. I have one more question. Do you know if chemotherapy, because she had stage 4 breast cancer about almost 15 years ago, and she's been in remission since, thank God for that. But could that also potentially be a cause of this?
That's one of the toxins that I talked about, medications. Most definitely. I saw a number of women who had breast cancer, who had chemotherapy, who've had neuropathy. And I've had family and friends who've also had it because of that. I've seen people who have recovered over time, and sometimes it's taken a number of years. And I've also seen some people who, after chemotherapy, did not recover. And a lot of times it was the painful neuropathy, because it involved what we call those small nerve fibers that are involved in the sensation of pain. And so people would have the pins and the needles and the stabbing and the shooting and the burning type of neuropathy. But it can also affect the other nerves, including the nerves that go to the muscle. So there could be mobility problems like you described your mother having. So yes, chemotherapy is definitely a consideration. Nowadays, there's some things that people are doing before and when they're giving chemotherapy, excuse me, to help prevent some of that or lessen that. But yes, that is a consideration.
All righty. Thank you very much. I appreciate you all.
Thank you for calling and at the table with us today. One thing that I wanted to mention also about the young lady that just called in, when she was talking about her mom, and I'm thinking that she mentioned that her mom was overweight too, and that's always a challenge, and she's worried about not wanting to be a diabetic, but there are medications out there that could help her, that she needs to be aware. I think a lot of times we've been scared of the past. We've seen what we have gone to different physicians and different hospitals or clinics, and we don't get the proper care. And so sometimes people are a little afraid about that. And so I would just encourage the young lady that called in to really talk with your mom and find out what's really going on with her, to see exactly if she can convince her to go in and get the proper care, because it's just going to get worse if she doesn't take care of it. Is that correct, Dr. Dotson?
That's correct. And I just want to add on to that, Karen, that if you have diabetes and you don't get the diagnosis and you don't treat it, you already have it. And ultimately, it's going to kill you because it increases your chances of having a stroke, having a heart attack, having kidney disease, not just having neuropathy, and having the weight that she has for her height would most definitely put her at risk for having metabolic syndrome and having diabetes. So she could have that in addition, because I've seen people who've had, more than one or have multiple causes for their neuropathy, and painful neuropathy, and pins and needles and all that can definitely occur with diabetes. I've had some people where I've done all the testing, and the only thing I can find is that they have diabetes that has not been well controlled, and it has damaged their nerves and caused them considerable pain. So I agree with you, Karen. She needs to get treated, and those things that treat diabetes and some of the options that we have now can significantly lessen the chances of a person having neuropathy or having worsening neuropathy, as well as all those other things that I mentioned.
Wow. And the other thing she mentioned too, and I'm just kind of making sure we cover all these types of concerns that she mentioned for her mom, is that she's taking pain medications. It sounds like it's over-the-counter pain medications, she said, for like a year and a half. And that can really affect a lot of different organs as well when you're taking that medication for that period of time. What's your thoughts on that, doctor?
Well, I don't know if she's taking over-the-counter only, or if she has some prescription, but she did say she was taking pain medication. And yes, you have to be careful. We think of things like Tylenol being, something, or acetaminophen is the other name for it, as being, something, it's over-the-counter, so it's safe. Well, you need to limit how much you take, because if you take too much, it can damage your liver, and it actually, can be a way that some people have lost their lives or have had to have a liver transplant from taking too much acetaminophen or Tylenol. Taking over-the-counter medications like Motrin or naproxen or naproxen or some of those medications, or Advil, which is ibuprofen, that taking too much of that can also cause problems. It can cause bleeding. I've had, patients in the hospital. I had a patient who had horrible headaches and was taking excessive amounts of ibuprofen, even though she was a nurse and she knew better. And she came into the hospital because she had a gastric bleed and was in the intensive care unit and almost died because of the excessive bleeding from taking that medication. I've seen patients who had horrible pain and were taking either ibuprofen, which is Advil, or naproxen, medication, and they actually had kidney disease because it can damage the kidneys. And and then of course, over-the-counter medications aren't something that people think are a problem, but we need to be aware of that there are some dangers. And prescription medications, narcotics, we all know the dangers and the problems of that, with people overdosing on narcotics and getting addicted to them, having to go through withdrawal. And then, of course, there's also evidence that they don't work well for nerve pain. So people may take more and more and more and not really have the benefit. There are some medications that we use that are not considered pain medications per se, that can influence the abnormal activity that's occurring in the nerves that have been damaged in peripheral neuropathy, that can lessen the pain. So we've used some of the antidepressant medications, some of the anti-seizure medications, but those also can have side effects and problems. And so if you can get at the underlying cause and treat the underlying cause and lessen the chances of a person having the symptoms of neuropathy that may include the pain, then they don't have to take some of those medications that may put them at risk.
I want to continue talking a little bit more about pain, but I know we have a caller on the line. And so I want to say, welcome, caller. Thanks for sitting at the table with us this morning.
Well, good morning, and thank you, Karen, for having me. You and your sister. Good morning. It's good to be on there with the dandelions got me whooped. I slept and I missed my boy Kevin Izzard there. But these dandelions got my lower back whooped. I need y'all to look at my lower spine.
Okay.
Well, good morning. Yeah, Tyrone W. speaking. Good morning, Mr. Rideout. Excuse me. Good morning, Mr. Rideout. Good morning, Milwaukee. A couple different things. The brain. The brain contains the elements of when this research is going on and everything. So our DNA. The brain tells the body everything about us, because our great grandparents all the way down to us, the seed has been put into us through the evolution of the evolvement and the evolution of the sperm. So the brain has a stem. I guess I was going to say, along with the spinal cord there, the brain has a stem that goes probably not as all the way down to the lower back, but it does have a stem. Is it safe to say that Some of this research can be enhanced or fast forwarded by studying more liquids from the brain as well as the sperm. If the penis is not a continuation of the brain, well, it contains our DNA. The sperm is supposed to be the white blood cells of because it contains everything in the DNA. So I will hang up and listen and say, well, can the research be enhanced by studying, the DNA through, different brain fluids as well as the sperm to cut through some of the chase and say, well, since the woman called about the her mother and all that, and the diabetes. Well, if you look into some of those fluids there, you may be able to get a head start on some of that stuff, I believe. So I will listen to you, and I'm not a doctor either, but I do read some. But I'll see what you got to say. I'm listening. Thank you. Thank you very much. Great weekend. Thank you, Karen.
Well, thank you for the question and the comments. So you are correct that the brain, and one of the reasons I'm a neurologist is I tell people, the brain controls everything. The brain and the nervous system controls everything and connects with everything in our body. The brain, we typically, think of the brain when we see that picture of the brain, which shows the cortex and all the wrinkles of the brain. But there's deeper structures in there that we could talk about, and ultimately, the lower portion of the brain is what's called the brain stem, and there's three components of that. And the brain stem then continues on as the spinal cord, and the spinal cord goes all the way down into the lumbar region. It usually ends at about the first or second lumbar spine level, and then the nerves continue on as they call it cauda equina, which is like a horse's tail is what it looks like, of nerves that then go on to go down to our lower extremities, and then all the nerves come off of the spinal cord that go to our limbs, our organs, and all of that. So there is spinal fluid that is surrounding the brain and the spinal cord and the nerves within the central nervous system area, inside of the skull, inside of the vertebrae. And we do study that fluid. The spinal fluid is something that, I've done lots of lumbar punctures on people where I'm wondering if they have multiple sclerosis, wondering if they have meningitis, wonder if they have an inflammation or infection of the brain or the coverings of the brain. And now people are also studying it to try and see if we can better diagnose Alzheimer's disease and some other things. And there's a whole host of things and ways that we diagnose using that. As far as the sperm, we know that it takes a sperm and an egg that provides the genetic material that results in the person. And so, it's potential that you can study some of those things. I'm not a geneticist, but I think that there are some opportunities there. And I hope that answers your question. Thank you for calling in.
Okay, we're going to take a quick break. I have Dr. Rose Dotson, who is a neurologist, with us. We have a caller on the line. Caller, hang in there. We'll be back. But we're also going to make sure before we leave today, we hear some of the other things that she's doing in the city. We'll be right back. Welcome everybody back. This is Karen Dotson from the Medical College of Wisconsin, and we're at the table today with my sister, Dr. Rose Dotson, who's a neurologist. And Debo, you had a question while we were doing break, and I want you to mention that to the listeners, I should say.
Good morning, Dr. Dotson.
Good morning.
I'm not used to saying that. It's usually, Karen Dotson, the Medical College of Wisconsin. But certainly good to have you here, and really informative show. We see a lot of interaction. There's a lot of conversation going on the chat as well in regards to exactly what you're talking about. Even some doctors that I didn't know were doctors are on here talking chemo and radiation, all kind of stuff. But my question was, my wife is a diabetic. And she's pretty good. She takes her metformin daily as she's supposed to, as well as the insulin. So she, is type 2, what have you. So, but she does have bouts where the neuropathy seems to, flare up or seems to bother her. She knows she's been diagnosed with it and she knows what it is. But are there things that she can do that will help with that? And certainly, is it irreversible reversible to the point that she could do some things that's going to make it better? I don't know. I just have wonder because sometimes I can't. We'll be just riding along and she'll go, oh, it's just like she'll get these sharp pains. It's like somebody sticking her with needles is the way she explains it to me. So can we talk about that?
Yes, we can. Thank you for the question. So the key thing that diabetics need to do is, one, make sure their diabetes is controlled. So, she's taking 2 medications. Hopefully her hemoglobin A1C, that measurement in the blood, is within a good range where her doctor wants it to be. And she's controlling her blood sugar. The other thing I want to mention is that we always talk about blood sugar being too high, which is what happens in diabetes, but the nerves also don't like the blood sugar to be too low. And so sometimes diabetics who are taking insulin or other medications may have bouts where their blood sugar drops too low. So we really want it to be regulated within the normal range as much as possible. And when you do that, that can lessen the chances that the neuropathy will get worse. And potentially there may be some improvement in the neuropathy. The other thing, when I see diabetics, or I've seen diabetics who have neuropathy, I don't just make the assumption that the diabetes is the cause, even though it's the number one cause. I always think about other possibilities. So when I would see a diabetic, I would just say, oh, you have diabetic neuropathy. Take this medication to try and help with your nerve pain. I would do laboratory studies to see if they had other causes for the neuropathy, because I've seen people with diabetes who also had a vitamin B12 deficiency or had a vitamin B6 deficiency or B1. So B vitamins are important for nerve function, and your doctor can do lab studies to check the levels to see if your B vitamins need to be treated with them, I should say, or if you have low levels. We know that, people with diabetes can have other potential underlying medical causes that can cause them to have neuropathy that may be treatable. So doing labs, I've seen some people with diabetes who've also had their immune system attacking their nerves. So there's labs and testing that can be done in regards to that. We're learning more about how, other vitamins are important for the function of our nervous system, including vitamin D. So I would always check for vitamin D levels just to make sure that a person's within the normal range. We know that vitamin D is important for helping with inflammation or reducing inflammation and preventing inflammation and helping the immune system to work properly. That's something that I could have mentioned when we talked about multiple sclerosis before, because there's definitely this association there with that autoimmune disease, but we're learning more about others. So I would recommend that if your wife has not seen a neurologist, that she considers seeing a neurologist and potentially a neuropathy, neuromuscular subspecialist in neurology to see if there is some other underlying cause, and that she works closely with her primary physician or her endocrinologist to make sure that her diabetes is optimally controlled.
Now, as I spoke to a moment ago, I've got some doctors on here. It appears that I didn't know were doctors. Compression. I remember my grandmother as a diabetic, she would wear these compression socks. Is that the types of stuff that will help? BAPS, which is a young lady who's commenting on the chat here, says make sure she's taking vitamin B12. It is important. Things of that nature. Are those good suggestions?
So as I mentioned before, vitamin B12 is one of those B vitamins that you can actually check the blood level of, and there's certain other tests that go along with that to determine why a person may have a vitamin B12 deficiency. As we get older, we absorb less vitamin B12 in the ileum, which is a part of the small intestine where it's absorbed, and we have an increased risk of having vitamin B12 deficiency, and that can be a cause of neuropathy, but it can also affect the central nervous system. I've had patients where it's affected their brain, it's affected their spinal cord, and so it's crucial for nerve function. I don't just recommend that people necessarily go out and take large doses of vitamin B12, because sometimes we've had to give people injection doses because they can't absorb it in that area of their small intestine. Taking a B complex or a multivitamin that has B vitamins in it is probably okay. If you have deficiency, you may need to be treated with another option other than that. So B12 is important, and it should be considered, and appropriate tests should be done. The compression, I'm not sure why the grandmother was wearing the compression stocking. Some people find that pressure or compression may help some to lessen some of their pain, and some people find that it increases their pain because they have the sensitivity of the skin and they don't want things touching.
This was,
on them.
if I remember correctly, she's been gone 20 years, but if I remember correctly, some of it was for circulation.
Yeah, and I was going to get to that part. So that's more likely. And especially as people get older, they may have some problems where there's incompetent veins in the legs where they don't pump the blood back up to the heart like they should, and you can get pooling of blood and get swelling. And some people, because of neuropathy and the nerves not working that go to the blood vessels, may also have that, or they may have other cardiovascular reasons why they may have some edema, so swelling, or some involvement of the blood vessels in the legs. So that's more commonly a cause for people, or a need, why people may need to wear compression stockings.
Okay. Thank you so much.
You're welcome.
Okay, we have a caller on the line. Thanks for holding. You've been holding for a while. So thank you and it sounds like you have your radio up. If you could turn down your radio a little bit.
It's off now. Thank you. I'm elderly. I'm almost 90. But my question is, every time I don't communicate very well with my prime care, and she always shuffle me off to a specialist, and it's not helping. I have neuropathy, that I know, and I have other complications. I'm not overweight. But is there, when I go to her and ask her, can you send me to some kind of specialist, and what would be the name of it so I could have more knowledge of what's wrong with me? Because my main purpose is I stay cold all the time. And I always say to her, my prime care, well, I can put more clothes on and I'll get warm. I'll turn the heat up. But sometimes you can't do that because it is warm outside and I'm cold. I stay cold, not. So does that have something to do with the nerve?
Thank you for calling. And actually, yes, it does. The nerves actually control the body temperature, and that's part of what the autonomic nervous system does. And that's another area of special interest and specialty of mine. The autonomic nervous system controls the skin temperature as well, because the autonomic nerves that can be affected in multiple different places, including with peripheral neuropathy, control the opening and closing of the blood vessels that go to the skin, which can determine if your skin feels cold or feels warm. And so, yes, it can be a nerve problem. It can be a part of neuropathy to have cold extremities. Primary care doctors have a lot to do. They take care of all types of problems, and I'm in awe of what they do, because I always feel like I wouldn't be able to do what they do, what Dr. Izzard and other doctors like him do. But one of the things that they can do and do well is to get you to the right specialist. So it's not uncommon that if you have a complicated or difficult problem, that they will refer you to see a specialist. And the specialist that you would see if they say you have neuropathy is a neuromuscular neurologist or a peripheral nerve neurologist. And a lot of times neuromuscular neurologists cover the peripheral nerve, but even within that subspecialty, there's a subspecialty of some neurologists that specialize more in dealing with peripheral neuropathy. And your primary physician should be able to connect you with a specialist that could take care of the type of problem that you have.
Okay. Okay. I think I caught it a little bit. At least when I go to her, I'll know some of the questions I should ask. Thank you.
You're welcome.
Thank you for calling in. We have another caller on the line. Good morning, caller. Thank you for joining us at the table.
Good morning. I have a question. I've recently been having some numbness in my feet at night, and it's basically just my toes. And I also, after some other tests were done, the doctor said I had curved spine, like my spine curves right and then left. And I was wondering how that might be affecting that situation with the numbness, and whether or not I should be referred to a neurologist, or what might a neurologist do or discover that would kind of pinpoint what's causing this numbness.
Thank you for the question. So it sounds like you have something called scoliosis, which
Yes.
is the curvature of the spine, which can be mild in some cases and can be quite severe in others. And it depends on where along the spine the curvature is occurring and how severe it is, but it could sometimes affect the nerves, and it could affect the spinal cord nerves. There are some people who, because of severe scoliosis, and as we get older, may have some what we call degenerative changes or arthritis type changes of the spine. On top of that, it may press on the spinal cord, or what we call compress the spinal cord. And that could, because the nerves that come from the brain that go all the way down to the toes go through the spinal cord, it could cause some numbness or tingling. The other possibility is if it's lower, it may affect those nerves that have come off of the spinal cord. So that is a possibility, but it also is possible that your scoliosis is not severe enough and it's not affecting the nerves or the spinal cord, and that you have a peripheral neuropathy in addition. So seeing a neurologist can help you determine that, and they can help localize where in your nervous system the problem is that is causing the numbness, hopefully. And then if it is related to your spine, make sure that you would see the appropriate spine specialist.
Okay, so if I see a neurologist, and would physical therapy help, or is it? I'm just trying to figure out and would I have to need a referral to get to a neurologist, or should I just make an appointment myself? Or
Sure. So a lot of times I would recommend that people, talk with their primary care physician, who can then refer you. And some neurology offices require a referral,
Okay.
and some of them might allow you to call and just say, I think I need to see a neurologist, and tell what your symptoms are, and they can tell you if they think that would be appropriate.
Okay. All right. Thank you very much. I appreciate the conversation.
You're welcome. Thanks for
Bye-bye.
calling.
All right, we have another caller on the line, and this might be our last call for today. Go ahead, caller. Thanks for sitting at the table with us.
Good morning. I appreciate this conversation. It's such an excellent topic. I have a question. I have a history of strokes in my family. My grandmother died of a stroke. My mother died of a stroke, and my father experienced a stroke. My mother had bleeding on the brain. My father had a blockage, I believe. Is there a test or something when I have my annual physical that I should ask my doctor for to look out for strokes, since I have such a history in my family? And I'll listen off the air. Thank you.
Thank you for calling.
Thank you for the question. So, a lot of times the reason that we have strokes in the family is because of the things that are risk factors for stroke that may be prevalent in our family. The hypertension, the diabetes, the obesity, also our dietary choices and the way that we learn to eat in our family. Those are a lot of times the reasons. There are some hereditary causes for a person having certain types of stroke. And, you said somebody had a bleed. Did they have an aneurysm, or which is a balloon formation on a blood vessel in the brain, and it can be thinner walled so that it can rupture and cause bleeding or break and then cause bleeding in the brain, and that can be hereditary. And so if I see somebody who has a family history of somebody having a ruptured cerebral aneurysm, then I would be concerned that maybe they do need to have certain testing done. But that's something that taking a good family history, learning what their other medical problems were and why they might have had a stroke can play a role in helping your physician determine what testing you should undergo. And then, of course, you need to be really careful about controlling your risk factors, because with that family history, having high blood pressure that's not controlled, diabetes that's not controlled, and being overweight, being obese, having excessive weight, which causes inflammation and causes changes in the body, including in the blood vessels, and not exercising, not getting enough sleep, not eating a healthy diet, not making sure your cholesterol and blood lipids or fats in the blood are within the level where they should be. Those are the things that are crucial. So that's what I would say. You want to make sure that your doctor is testing you for all of those things that can be tested. And then based on your family history and more details, the doctor can determine if some more specific testing needs to be done. There's some people that have genetic abnormalities that cause problems with blood clotting, and they have increased chances of bleeding or increased chances of having clots. So yes, there are some potential tests that could be done depending on the details of your history and your family history.
Thank you, Dr. Rose Dotson. I wanted to mention before we get off the air, we have a couple more minutes and we're going to have to go, but I wanted to mention that also, Dr. Rose, that you are a co-investigator for Clinical Transitional Science Institute at the Medical College of Wisconsin. And what area is that you're involved with?
So I have the privilege of working with a heart specialist and with a person who specializes in cholesterol problems and lipid problems, and we're putting together a research protocol that is getting approved so that we can actually look at the population of Milwaukee, recruit people through a faith-based organization to look at obesity and cholesterol, and what people know about heart disease, and then follow them over about 9 months to see if there's changes in those risk factors after we provide them with some education and some ways that they can make some changes.
Okay, and that's going to be coming soon, right?
Yes, it will be.
Okay, so we'll watch on that and bring you back to talk more about that.
Wonderful.
I also wanted to mention too that you are an advisor for the Community Water Services LLC with the Medical College of Wisconsin, advancing a Healthier Wisconsin grant. You are also the Health and Wellness Director at Cross Lutheran Church in Milwaukee, Wisconsin. You're on the board of directors for the Bread of Healing Clinic. And my sister just don't stay still, does she? So she is involved. She says she's retired, but she is just starting to go. So I want to thank you for taking the time out of your day to come in to sit with Dr. Kevin Izzard and myself at the table. We enjoyed you. The listeners are just calling in and they just keep calling. So I had to cut it off. So we'll just have to make sure that Dr. Rose Dotson gets a chance to come back and talk to someone, because our community really doesn't really get that opportunity much to do it. So thank you for coming and being on the show today.
You're welcome. Thank you for the opportunity, the invitation, and thank you for what you're doing for the community. This is really important work that you're doing, and I have to say how proud I am of my little sister.
Thank you. I appreciate it. This is Karen Dotson from the Medical College of Wisconsin. We are here on the first and third Fridays of the month to talk to you, to bring you information that's going to help you. Hopefully that helped you today as far as what Dr. Rose Dotson was able to give to so many of you. And, just keep listening so we can, and just let us know too, whatever else you want to talk about. I'm always open to that. So just call us when we're on the air and let us know some other people or different type of topics you would like to hear as well. We'll see you on the other side. And that will be in 2 weeks from now? Well, actually 3 weeks from now. Because that's right, we got an extra Friday in the month of May. So I'll see you back on June, the first Friday in June. Take care. God bless.